right. So just a little historical retrospective. In 1980, Fujita presented the UPPP at the American Academy of Otolaryngology. And he got his idea from Ikematsu, who wrote a paper in 1964 regarding snoring. And it was in Japanese, and Fujita, of course, could read Japanese. And so he presented it, and then there were some publications in journal articles. And then Fairbanks out of DC wrote the first surgical text with a lot of contributing authors. And Simmons, he was the one that had perhaps a little bit more complications because he was more aggressive at resecting the soft palate in those days. But an early attempt to identify levels of obstruction was the Fujita class, where he simply classed it as palate obstruction, palate and tongue obstruction, or tongue obstruction. And clinically speaking, it was more or less your best guess with the patient sitting in the chair and deciding where the obstruction was. And of course, there was flexible laryngoscopy at that time, but you know, it was a difficult choice. So Aaron Shear out of Albany did a meta-analysis in 1996, and this is a landmark paper where he looked at all the data up to that time, meta-analysis, and found that clinically selected type 1 patients would have a 52% success rate with the UPPP, the traditional UPPP, and 41% of all unselected OSA patients. And he told me that he was kind of persona non grata at the Academy for a number of years because this showed that UPPP wasn't the godsend for sleep apnea. So people were still quoting this even up to 5 to 10 years ago, especially in the sleep medical community, where they said the surgery doesn't work or it's too aggressive or for a variety of reasons. But bottom line in this slide is that the Fujita classification did not explain why UPPP failed in almost half of the type 1 patients. So Katz and Tonis decided that it was medial wall collapse that was the reason for UPPP failure. Friedman out of Chicago felt it was tongue base, and then Woodson in Minneapolis felt it was persistent palatal obstruction. So all three of them were right, but on different patients. The pharyngeal collapse occurred at more than one site, and so UPPP for cure was kind of limited as an isolated procedure. So we start talking about multi-level surgery. And so this is kind of the preamble as to selecting how we can identify successful patients. So the tongue is one variable, and in this slide, these are my photos, not the upper one, but the 4 at the bottom, showing different tongue sizes. Below the occlusal plane, above the occlusal plane, you can see part of the uvula, and then lower left, see only the soft palate, and then on the right lower one, the tongue filling the oral cavity, you can see only the hard palate. So tongue certainly can play a part. And Friedman in 2002 came up with a staging system to try to anticipate success of the UPPP operation. And he looked at tonsil size and tongue size and put them together in a staging system. It was really remarkable. And found that with a stage 1 patient, large tonsils, small tongue, you could get an 80% success rate with the UPPP. Or if they had big tongue and small tonsils, you're talking about an 8% success rate. So he threw in a simple tongue procedure called the radiofrequency tongue reduction. He increased the success rate in the stage 3 patients from 8% to 44%. So basically, we're making decisions who to operate on and what procedure to do. But the basic premise is that there are multiple levels of obstruction. And understanding this is essential to achieving the cure. So you have to correctly select the procedures. And the problem is there are so many procedures, and for many years that was the case. They talked about which procedures were available, and I used to ask, well, when do you do what? Well, you start with a routine clinical exam, and that can only go so far sometimes. Flexible laryngoscopy adds to it. And then the Mueller's maneuver, which is kind of the opposite of the Valsalva, to look for pattern of collapse. Cephalometrics, which was more of a dental evaluation, oral surgery evaluation to look at facial skeleton. All these things were found to be incomplete. They helped, but they weren't perfect for assisting us in selecting the case. So basically, the awake exam was not representative of what really occurs during sleep, because there's increased muscle tone, even in a relaxed state, is not as relaxed as during sleep. So the question came up, how do we assess one during sleep? There were a couple studies where they actually placed an endoscope in the nose and they watched the patient fall asleep. That was kind of a rough thing to do, more research related than clinical. And Croft and Pringle in '91 in London, England, came up with the drug-induced sleep endoscopy. So that's one of my residents. He became an otologist, so he loved what he was doing. Indications for sleep endoscopy is when the site of obstruction is unclear. And the first one I did, maybe I mentioned this, was probably about 10 or 12 years ago, when the patient came in, was a relatively thin man in his mid-40s with moderate severity obstructive sleep apnea, somewhere around 30. And his exam was normal. I could not find obstruction even with flexible laryngoscopy. So I did a sleep endoscopy. It was the palate. We treated the palate and he was cured. Another indication, they've had prior sleep surgery, but the results were less than optimal. Or you can use it in any candidate who, or any person who's a candidate for surgery, or even one who is wanting to use an oral appliance. So the conclusion is that sleep endoscopy can reveal sites of obstruction that are not otherwise detectable. That's what they said in their paper. So the key points to guide you are the site of obstruction, the level and structure involved, and the pattern of change. So the advantages were that it was a dynamic assessment of sleep because of muscle relaxation, and the artificial sleep represents normal sleep. And with sleep endoscopy, many modifications were proposed, as well as how to describe what was found on the endoscopy. So the protocols are not standardized. Kazarian out of Los Angeles is the one probably who's most looked after in this country today for adults. And he's a good guy. And then there were several other papers looking at different protocols to achieve sleep endoscopy. But one important thing is you and the anesthesiologist must do this together. If you're operating independently and they don't know what you're doing, the results become less reproducible. We have actually a fairly good relationship in our hospital, but it took 2 years to get there. And sometimes what comes up is, don't tell me how to do my job, but that's actually the wrong approach. It's how can we work together on this? So as far as sedation protocols, there were a number of them that were proposed. Midazolam or Versed was the first one used back in the 1991 paper in England. And different protocols were developed. You don't have to memorize this at all. I'm just illustrating that Eichler went ahead and bolused propofol and titrated it to snoring. And then Ravensloot titrated in just a slightly different way and gave an extra bolus when patients were extremely nervous. I don't see that actually. Or if they habitually used antidepressants or sedatives, sometimes they needed a higher dose, but that is not something that I find to be very important in proceeding with this. And then Midazolam with propofol, I thought this was an interesting way to do it, and I'll have to consider it in some patients beyond the scope of this presentation. But the disadvantage with Versed is the half-life is pretty long, and there's more muscle relaxing effect. And so you can have different results based on the examiner. That's what Maurer found in 2006. So SOARS tried to do a standard protocol and strictly prohibited other medications like benzodiazepams, like Versed. And he proposed a target level of sedation, light sleep with arousal to tactile but not vocal stimulation. I don't find that as helpful because sometimes you touch the patient's nostril and they'll just turn their head. So this is not my accepted way to do it. You can use oxygen by blow-by or face mask. When we first started back 10 years ago, anesthesia, they're looking at anesthesia and they are very antsy about oxygen. But you have to tell them that these patients will desaturate down into the 70s at night, many of them. And that we're just trying to simulate what they do during sleep. We're not trying to give them general anesthesia. So if the anesthesiologist doesn't work with me very often and they're nervous, I'll say, okay, you could use a blow-by. We did it originally through a facial mask, and then now we don't use the mask anymore. So continuous infusion, sometimes with boluses, and I find actually the teenagers to be the most difficult to do. But you go slowly. I tell the patients, we're going to drift you off to sleep over 5 or 10 minutes. We turn the lights down. We tell everybody to be quiet, and then we proceed. I'll take a first look while they're awake, and that way we have a baseline of what things look like with muscle tension, even though they're relaxed. Because sometimes you'll see the tongue fall back during sleep and not during the awake phase. So that can point to a procedure such as a tongue suspension suture as one option. So moving on, let's see. This study, I think, was a great study. It had 15 patients with 4 controls where they did 2 PSGs. One was a normal PSG, and then one was with propofol. And they found that both the apnea-hypopnea index and minimum saturation really didn't differ significantly. The oxygen was just a little bit lower with the propofol. And they found that in the controls, they could not induce snoring, but 100% of the OSA patients snored in this study. And they found that N1 sleep was decreased, N3 sleep was increased. There was no change in N2, and really you didn't see REM. I think there was one study. Did you lose me, or are you guys still there? Okay, I thought I lost my internet. One study showed that they had to be asleep under propofol for a couple hours to get REM. So that's not a big deal, I don't think. The stage 1 sleep, that first number I have to go back and check on because that doesn't seem right. But these are the numbers with and without propofol. So propofol changes the sleep architecture slightly, but permits proper evaluation because you get the muscle relaxation that they see during sleep. One thing with propofol is that it has a rapid drop-off for muscle relaxation. So that's why you don't want to over-sedate them. Okay, the conclusion of this study is that you can't induce snoring in patients who don't snore. You can't induce apneas in patients who don't snore. If you over-sedate, they just collapse and stop breathing. And the retest reliability is good. Kazarian just put out a study with, I think, 500 patients about retest reliability. And that it correlated with improved outcomes regarding palate surgery. So the UPPP actually doubled from the 41% overall success rate with the share meta-analysis study, 80%. Again, the indications when obstruction is unclear or when they've had surgery, but results are less than optimal, they have residual OSA, or any patient who's candidate for surgery or any patient for an oral appliance. So as you know, you place the endoscope through the nostril and then position it at different levels. So basically you would look down at the palate from the nasopharynx and then position the endoscope at the level of the uvula to assess the hypopharynx and mark the characters of these different sites. So key points again, the sites of obstruction, the structures that are involved, and then the pattern of airway change. So you can use these things to formulate a treatment plan. Meantime, for sleep endoscopy, yeah, about 15 minutes. So sites of obstruction, I like this paper because it showed that on the table on the right, that 12% of patients can have 6 sites of obstruction simultaneously. And so it becomes your job to kind of tease these things out and decide what needs surgery and what needs to be operated on first. And sometimes you need to take care of the primary site of obstruction before you see a secondary site. So this came out of Jonas Johnson's textbook. He's from UPMC Pittsburgh. And I love this diagram showing the different patterns of collapse. And we'll show these with some video in a few moments. We have anterior posterior collapse. And that's very important in selecting your Inspire hypoglossal nerve stimulation patients as well. Circular collapse, which excludes them, and then transverse collapse lateral to medial, which is a more difficult obstruction to improve. So source paper showed different types of collapse in different levels of the airway. And we're going to show those to you in just a moment here. So from the archives. Okay, so here we have a lateral retropalatal collapse. Yeah, give it a moment, wait for it. So there's some circumferential involved, but you see the side to medial component. Okay, now lateral retropalatal collapse again. And so a lateral expansion pharyngoplasty would be very helpful with this. And then AP retrolingual collapse. So here you see the tongue actually falling back. And so a suspension suture procedure or a hyoid suspension or both would be helpful in a situation like this. Okay, here we have a massive tongue which actually overrides the epiglottis. So hyoid suspension probably would not be as beneficial in this patient, although it probably would help some. But you need to think about maybe a midline posterior glossectomy to improve this patient. Sometimes a radiofrequency tongue reduction will give you some benefit too, but this is quite a large tongue. And similar retrolingual obstruction with a large tongue here. See a little bit of lingual tonsil hanging out behind the epiglottis, but not very much. So massive tongue. Now this is the retrolingual collapse from lateral to medial. Kind of difficult, and maxillomandibular advancement is good for this, but you have very few takers. And hyoid suspension should help with that as well. And then the epiglottic collapse. I think this is actually a hard one in adults, an easy one in kids to take care of. I think the adults need a different procedure than kids, and what some of the folks are doing is they're actually doing a partial epiglottic resection. But I would do a hyoid suspension on this patient first before I did anything to the epiglottis. That's my personal approach. Now, just to touch on the pediatric sleep endoscopy. This one had a moderate adenoid, a transverse epiglottic collapse. It's just folding together immediately. And large tonsils and palatal snoring. So the tonsils collapse laterally, and Dr. Carr has a template, well, we use together, she may still be using it, that talks about how to mark this. and then a transverse epiglottis collapse, which is very isolated. I haven't seen that in adults very often at all, but I have seen some, and it's one reason for CPAP failure. And so we treated an epiglottis with one patient who was on a BiPAP of 24/20 and still wasn't able to get controlled. So we treated his epiglottis, and he was able to go back on BiPAP. He was kind of a large fellow. Now looking at retrolingual collapse in this patient, so we have a little bit of adenoid tissue there. But look at that tongue, just sitting on that epiglottis. And there's a little bit of lingual tonsil down there too. So this patient, you can start with a lingual tonsillectomy, but I would think that lingual tonsil and midline glosectomy would be helpful. On the right, 10-year-old heavy Downs patient had a obstructing septal deviation. Some of the blood is resident. This was one of our earliest sleep endoscopies, and for a senior resident, it was a little bit rough, but he was downhearted because he did an adenoidectomy on this patient just 6 months earlier, and you see complete adenoid obstruction. And then you see massive bilobed lingual tonsils, and then a folding epiglottis. So he was much improved, but continued to gain weight until the point where he was beyond our surgical treatment. Eric Kazarian came up with this VOTE classification, VOTE for velum oropharynx tongue base epiglottis. And it's fairly straightforward. You're looking at the degree of obstruction as being non-partial or complete. And then the configuration is how does it collapse, AP, lateral to medial, or concentric. So let's take just a little look at this degree of obstruction, non-partial or complete. And then the oropharynx, obstruction due solely to tonsils or lateral wall with or without tonsils. And then the configuration, just like in the Jonas-Johnson diagram of collapse. Now, out of Europe, they came up with this NOH classification, which I really haven't seen other than this paper, which is kind of interesting. It's nasopharynx, oropharynx, hypopharynx. Seems pretty straightforward. And obstruction pattern again. And then they graded it as you would grade a Mueller's maneuver in 25% segments. So this is just for your information. Treatment recommendations based on DISE. This is actually a subject of another lecture, but as you run down, their MAS is mandibular advancement splint or mandibular advancement device. That's an oral appliance. You can actually look for this during DISE by having the anesthesiologist or anesthetist advance the jaw by about 5 millimeters or so. And if the pharynx opens and they have teeth, then an oral appliance may be an option for them. FDA has approved oral appliance therapy for mild to moderate sleep apnea, but if you find that it helps under DISE, you can offer it to a severe obstructive sleep apnea patient as well. So we talked about this once before in the anatomy lecture, where Tucker Woodson came up with the structure of the pharyngeal isthmus, which is basically the shape of the soft palate, talking about a vertical drop-off, intermediate drop-off, or a circular configuration. He had defined 3 anatomic points: the hard palate, which is basically the posterior edge of the hard palate, which is very thin. How far posteriorly does this ride? Because he talked about resecting a portion of it in order to advance the palate anteriorly. The knee or the bend in the soft palate, we're looking from above, the velum or the filamentous part of the soft palate. So these are my photos. Again, trying to illustrate a vertical or slit-like airway where transpalatal advancement would probably be very beneficial. And on the right side, the oblique, where standard UPPP or perhaps a expansion technique would be used. So he characterized at the very top line where he says soft palate, upper, mid, and lower. That probably should be a little bit clearer if I put hard palate, genu, and velum as far as the lower. So the vertical soft palate shows the nasopharynx is narrow at all 3 levels, where the oblique or circular soft palate configuration is narrow at the most inferior end. This is a side view showing the proximal narrowing with the vertical palate and distal narrowing with the oblique character palate. So distal narrowing, conventional UPPP, or maybe a lateral expansion pharyngoplasty. And then for the vertical drop-off, transpalatal advancement, sometimes with the UPPP. I used a variant of the UPPP called a uvulopalatal flap, which I've used on some patients. So what Dr. Whitson did initially was to remove a segment of the soft palate and then to draw it forward. He's since modified his technique, but I like the old way better because I get good results with it. Okay, what about the Inspire hypoglossal nerve implant? To be eligible, a patient needs an anterior-posterior collapse or narrowing. And so this patient would be eligible for the Inspire, whereas this patient with a circumferential collapse would not. And this came out of the original paper out of UPMC with Ryan Seuss, where they did a retrospective on this and found that the patients who failed had this kind of palate configuration. So a DISE candidate, going through the nose, you've seen that view yourself before. Okay, more of an AP collapse. Pretty complete, a little bit of snoring there. And then large tongue, see only the retinoids pretty much of the endolarynx. And there's the AP collapse. So that one would be a candidate for the Inspire. This one, however, is a non-candidate. And part of the theory of how the Inspire works is that as the tongue is drawn forward, the soft palate also is drawn forward because of the palatopharyngeus or the posterior pillars that are attaching the tongue and the palate. So, final thoughts. Some sites suggested by clinical exam had no obstructive events at all during the drug-induced sleep endoscopy. So sometimes these patients would get unnecessary surgery, and with DISE, it's possible to have an improved success rate, and I believe that. And similar success, but with less surgery, because you're no longer guessing like we used to. So Eichler found that 2/3 of patients showed at least one changed surgical recommendation compared to a clinical exam. And the palate was seen to be obstructing in 21%, even though palatal intervention had not been recommended. Like my very first patient, who I could not get him to obstruct in the clinic, even with a Mueller's maneuver. So you see obstructions even in apparently normal palates when they're not expected. Not suspected of having an airway obstruction. You know, and just to mention in kids, I saw a patient today in the clinic that we did a DISE on, an adenoidectomy. His tonsils were 2+, and in the mouth, they looked like they probably were obstructing, but they were nowhere to be seen obstructing in the sleep endoscopy. So, awake versus sedation in DISE. In this paper with 250 patients, they found awake and sedation findings were identical only in 1/4. And then you see the percent discrepancies listed below. And there was a marked disagreement in the hypopharynx obstruction. See that? So this is just supporting evidence. You don't have to memorize these numbers. So as far as choice of agent, Midazolam, longer half-life, Propofol, 4.5-minute half-life. And most of the adult endoscopies in this country now are done with Propofol. Sometimes they might supplement with Midazolam. And early on, one of my anesthesiologists really wanted to try it with gas. Forget which inhalant agent he used, but it just did not work. So, confidence. This is a quote. And sleep nasendoscopy, that's what they call it in Europe, would not be possible without the close partnership between us and the anesthesia. So we work together, and the results are actually reproducible. but when you work apart, and sometimes when you first start this with some people that don't know what you're doing, you can have some difficulties, like I did my first year, especially here. So that's the end of it. Do you have any questions for me? I'll take that as a no. Now we're off. All right. Well, nice talking with you all again. And Adrian, are you there at all? I want to make sure I was coming through. Okay. Okay.